You're listening to the Animal Heartbeat. My name is Kieran and Jose.
Hi, and I'm Jose Nogumatos. This is the world's only podcast dedicated to veterinary cardiology.
Welcome, everybody, to this very special episode of the Animal Heartbeat. Thank you all for listening. Jose and I are honoured to be here today with Robert Hamlin, who is the Stanton Youngberg Professor Emeritus in Cardiology at The Ohio State University and the Principal Scientist at Q-Test Labs. Robert, welcome. Thank you so much for joining us. It's an honour. I'm looking through your CV here, and I can see that you got your DVM at The Ohio State University, go Buckeyes, in 1958. Is that right?
Right.
Fantastic. You must have seen some monumental changes in the world of veterinary medicine, veterinary cardiology. And I think for me, I guess one of the biggest changes was probably something you were directly involved in, which was forming the ACVIM, the nature of veterinary specialty. Tell us a little bit about that and the impact that has made on the veterinary profession.
Well, in the U.S., Dave Detweiler really started veterinary cardiology at the University of Pennsylvania.
Okay.
Brilliant guy, very nice guy, and extremely knowledgeable. When he died, it was a terrible loss. And so he developed the comparative cardiovascular studies unit at the University of Pennsylvania, probably in the 1950. And then more and more people became interested in it, really due to David's contributions, and I started. I was president of it in about 1970, and it was truly a great experience, meeting some very nice people, and we believe that the College of Internal Medicine improves the quality of the practice tremendously.
And I think without the ACVIM, there would be no ECVIM. And recently, of course, the ACVIM has supported the Asian College of Veterinary Internal Medicine, which is a potential to have a huge impact across the globe. So I think it's fantastic stuff. Welcome, and thank you very much for being here.
Thank you.
Thank you very much indeed. It's again a huge pleasure. If we think about cardiology in 1952, what were the big differences you see from cardiology nowadays? If we start, I don't know, for example, with disease prevalence, do you think the disease prevalence have changed?
We didn't really deal much with congenital disease many years ago. We had pulmonic stenosis, and PDAs were by far the most common congenital defects. Then, with evolution of time, aortic stenosis became even more common than probably the other two. The way things evolved was when echocardiography entered the scene, there was a tremendous increase in interest because we could actually see the defects in real life. And as you know, there was an explosion. Then when pimobendan hit us, there was another explosion because it revolutionized. When I started in the early 1950s, it was really quite simple. We had only 3 drugs. That was whole leaf digitalis, which was ground up and given as an oral tincture. And we had a diuretic called meraluride, mercurhydrin. And then we used Nux vomica, which is strychnine, to make the animals feel better. And that's all we had. And you see, pharmacology for heart disease really was virtually non-existent. Now, of course, we have so many different drugs, and because we understand so much more about it, the diseases have evolved to mitral regurg. About 85% of the cardiology is mitral regurg, and dilated cardiomyopathy is a relatively small amount, but in Doberman pinschers, in which we saw it most frequently, it was you saw a Doberman pinscher coming into the office, you knew what was going on. Big dogs, dilated cardiomyopathy, the little dog's mitral regurgitation. And now they've evolved into breed predilection. And of course, we see Cavalier King Charles Spaniels with ubiquitously with mitral regurgitation. And the interesting thing is probably all mitral regurgitation has a strong familial character. That is to say, they're not born with it. We don't see it. It's not congenital, but it is clearly hereditary because we see it in certain breeds and certain families. So things have changed enormously as cardiology has changed, as pharmacology has changed, and mainly as instrumentation has changed. We had X-rays in those years, which were about 1/10 of a second exposure, which is a lot of motion. Now we have PET scans and the likes, which are improve the quality of our diagnosis.
So for our listeners to understand and for us to understand, if you take us back to 1960, how would you approach a case coming to the clinic? I have to say that I'm always very jealous of, I'm sure, of your clinical skills. I think we are losing our clinical skills. We'll talk about cardiac auscultation in a second.
I was going to say the same thing.
Yeah, and I would love to have had the opportunity to see you examining a patient, Robert, because I'm sure you would detect a lot of, or you gather a lot of information on a clinical exam, which we just don't anymore. So we talk about cardiac auscultation in a bit, but could you just guide us? If you see a dog with a murmur, or you see a dog coming to you with a suspicion of heart disease, where would you focus your clinical exam? Which diagnostic modalities would you use besides thoracic X-ray? How frequently and when would you do invasive angiography, for example?
Well, you're probably asking the wrong person about that. I spend my time, an enormous amount of my time with a physical exam, just with my eyes, hands, and ears. In those years, we did a great deal of percussion, and we auscultated bronchial breath sounds because when they have heart disease, of course, they have lung disease as well. You really can't have one with the other. And I'm waiting for the respiratory community to catch up with the cardiovascular community. I don't think we're very good at diagnosing respiratory diseases, and it's kind of a pity that people have forsaken some of the hands, eyes, and ears for instrumentation. It was a lot more fun in those years before we had the electronic gimmicks, and we did, I think, a much more accurate assessment of the patients. In the 1960s, we had radiographs, auscultation, percussion, palpation, and auscultation, percussion, palpation have just about left us. You know that there was a study conducted on humans in which they took freshman medical students who were in their first year of medicine, and they took two of those freshmen and they talked to them about echocardiography using a point of care echocardiograph. And they went to the ward and examined a ward full of cardiovascular patients with a bunch of board certified cardiologists. And these two students, freshman students, with having virtually no exposure to cardiology, but what they learned with this handheld device, perform almost as well as the board certified folks. In point of fact, a good observing clinician can usually diagnose things quite well without the aids. But we confirm, of course, disease with echocardiography. Nowadays, of course, I think instead of calling people cardiologists, you might call them echocardiologists because they spend most of their time and the vast majority of their income is based on echocardiography. But if you take a look at what happened in the 60s, there were some spectacular diagnoses. Dave Detweiler was one of them, by auscultation, palpation, and percussion. It really has changed things dramatically. Well, let me say one very interesting example. I taught for 50 years a course called Heart Sounds, Murmurs, and Pressure Pulses. And I had a course in advanced electrocardiography with some very, very good students. And I just said, well, we can't meet this Friday because I've got to go and give this talk at the FDA in Washington. And they said, well, what are you going to talk about? I said, well, of course, electrocardiography, because that's really the only device we had besides X-ray, and the X-rays were in generally terrible quality because of the duration of exposures. One of the students in this advanced course, they were very bright students, said, well, why did they invite you? I said, I suppose that it's because I've seen thousands of dogs, and somebody thought that that what I did was okay. And they said, well, how do you know you were right? And I said, boy, what a burning question. In point of fact,
the question every teacher hates.
In point of fact, I don't, they should have asked me, you would ask me now, what is your sensitivity and specificity for diagnosing disease and for selecting drugs? And in point of fact, we have very little confirmation of what we're doing is correct. And so I had to admit that I have not the foggiest notion how many times I made errors. I run OFA clinics where we examine mainly younger animals to see if they've got heritable heart disease. Mm-hmm. And I call the OFA at the end of each year. I said, have you had people say what I've done? How often have I been right? There is no data to support that. So if you ask me, how do I know I'm right? The answer is I have not the foggiest notion. And I ask my colleagues, how often have they made errors? And nobody answers. Nobody answers. The conclusion might be they never make errors. And I think some of the more dogmatic of us are confident we never make errors. I absolutely know I make errors. And I know other people make errors because I see some of them. And I know they see some of mine. But nobody keeps track of this. So where do you go to get an expert? And the answer is you go to a person who has some follow-up. And the follow-up is very, very poor. The OFA, for example, has no idea how often people judge the presence or absence of heart disease, and it never gets confirmed.
Yes, so, it's very difficult, isn't it?
Yeah, it's enormously difficult, and it must keep us humble because I always ask people, sensitivity and specificity, what are they? And never get an answer. Never get an answer.
Yeah, I think one of the real challenges that I see, I think, in cardiology specialty practice now is that there isn't great validation of our diagnoses, and certainly in some business models, a cardiology interested vet or a cardiologist makes a diagnosis and never sees that animal again. Mm-hmm. And they don't have that follow-up, and they don't have that sort of understanding of outcome, because I guess short of some sort of secondary validation of the diagnosis, the best surrogate we have is outcome. Do they live longer? Have they got a better quality of life after seeing us and after what we've done? And we don't always have that outcome data, do we?
And have you seen a study that reports outcome, which is really duration and quality of life? That's how we evaluate outcome. Have you ever seen a study in which the people said, well, we have these now 10 toys or techniques, or 15 maybe, to evaluate the patients. Have you ever seen something that reports the time that you make a correct interpretation, which is based upon quality and duration of life? And we know that the dogs with heart disease live longer, but it's hard to say which of the techniques we use allow them to live longer. The FDA now understands they don't care what a drug does to cardiac output. Nobody complains that their dog has a bad cardiac output, and
Right.
it's not really measured very often. And so what we need are follow-ups to find out how good or how bad we are. And it's very disconcerting to say that how good we are when we really don't know.
I wanted to just pick up on something you said about the learning curve there. You talked about the freshman medical students. And I remember a study out of the RVC group a few years back now, looking at auscultation.
Yeah.
And it was by the cardiology team, and they looked at final year students, new graduate vets, and then people who'd undergone specialist training, and it was about their confidence in auscultation and their ability to grade heart murmurs. And what was interesting is it seemed that over the course of their final year of clinical rotations, the students' level of confidence increased in auscultation. But then until people undertook specialty training, there was absolutely no improvement in confidence from a final year student through to people who were 2, 3, 4, 5 years out of university. So that tells me that it's really hard for people to continue learning about auscultation and probably those other physical exam techniques as well after they graduate from university.
Yeah.
So what are your tips? What pearls of wisdom can you share on auscultation of the heart, the lungs, with people out there who might be struggling with their confidence in that?
Yeah. Let me approach that question with this response. Innocent murmurs. What is an innocent murmur? Okay. First of all, to my mind, there can never be an innocent murmur. Why? Because if there's a murmur, it means there's blood flowing at a high enough velocity to produce turbulence.
Yeah.
And it's well known by the physicists and the fluid mechanician that anytime a pump pumps a liquid at a high enough velocity to produce turbulence, it spends a certain percentage of its time wasting to produce that turbulence, because turbulence doesn't move blood downstream. It moves blood in a turbulent manner. So the ventricle is consuming more energy per useful work if there is turbulence. So there really is no such thing as an innocent murmur. And it's interesting, though, a golden retriever and a boxer are allowed to have grade 1 or 1.5 murmurs out of 6 as normal if everything else is normal. Okay, but you see, even though the animal may not be symptomatic and it may have its life shortened only very, very little because the amount of energy wasted in creating turbulence is not that great, still, how can it be that we judge a golden retriever and a boxer, the intensity of the murmur, so casually, when a cocker spaniel with the same murmur is not considered innocent? So, to answer the question, we don't really know because we don't have, as you pointed out, good follow-up to find out whether we were correct. If you say that a murmur with a thrill is always bad, and a murmur that's a grade 1 in a boxer or a golden retriever is never bad unless there's an echocardiographic corollary of it, how would we know that the innocent murmur is really innocent? And so it's a very, very ticklish question. Do you know when a murmur is innocent?
I always talk in likelihoods. So if I'm talking to a vet who's seeing practice and I'm auscultating something, I think I think it's likely this is an innocent. Well, you see, I don't use the term innocent murmur. I would say a flow murmur or a non-pathological murmur. I'm not quite sure which of those I prefer, but I find people use different words, so I use different words to try and translate my thoughts. But I would always say it's possible we've got a mild to moderate subaortic stenosis here. Or a pulmonic stenosis. It's possible we're underestimating. So I don't think you can talk, or for me, speaking as someone who relies a lot on echo, I don't think I can be 100% confident on auscultation of what my clinical findings are, with perhaps the exception of mitral regurgitation in a dog, small breed dog over 6 years of age. And that's because of pre-test probability, isn't it? So my positive predictive value, of course, is very, very high in that population. If you have a low-grade murmur in a sight hound, a boxer dog, an English bull terrier or something that's less than 2 years of age, I find it hard to know what the cause of that is based on auscultation alone.
Yeah. And then it's so important to understand that anytime blood flow is turbulent, it costs a little bit more, maybe a lot more, to the ventricle that's generating that turbulent flow. You may not see something happen tomorrow, but maybe it will abbreviate their lives. And it's very difficult. It's wonderful that we have the echo, but you know, in the U.S. and I think all over, therapy is based upon echocardiography. You ask a person, well, you want to know is the lung wet? So you take an X-ray, but what about percussion and auscultation of a bronchial breath sound? I mean, most people don't even know what a bronchial breath sound is. They don't understand that all breath sounds are made by turbulent flow going through the trachea, because the air goes through the trachea at a higher velocity than through any other structure. It goes through the small airways at very, very low velocity, and there are virtually no vesicular breath sounds made over the diaphragmatic lobes. They're all made in the trachea, and you hear them over the diaphragmatic lobes because the turbulence is made in the trachea, and that is transmitted downstream in the direction blood flows, and you hear it. And if the lung is wet and heavy, then you know that the animal would be breathing more rapidly, because that's the way an animal with a stiff lung breathes. It breathes more rapidly, the tidal volume falls, but the minute ventilation is sustained because by increasing the rate. So you look for respiratory rates, and you can't get them in the office because a lot of the animals are upset. So I always have the people, and when I talk to them before they come to the office, I say, tonight, when the house is quiet and the dog's quiet, watch the chest go in and out, count the breaths in 15 seconds, multiply by 4, and write that number down. And if you find that number going up slowly and maybe very, very slightly, you know that animal is probably getting a wet, heavy, stiff lung. And so it make observations of bronchial breath sounds, respiratory rate at rest, not when the animal's upset. Then notes of percussion. You can percuss wet lungs. And how many people percuss nowadays? In 1950 to 60, everybody percussed. And why? Because X-rays were not terribly good, and we couldn't confirm wet lungs. But if you look at these subtle signs, notes of percussion, respiratory rate, bronchial breath sounds, crackles, and whether the crackles are rough or fine, these all give tremendous insight into whether or not the animal needs to be given a diuretic and or something. For example, let me ask you this question. Why do animals who die from heart disease or lung disease slowly, not due to an arrhythmia, why do they die?
Jose, do you want to field this one?
Yeah, my understanding would be they would die of severe hypoxia.
They die of asphyxia due to fatigue of muscles of respiration, unquestionably. Now, if they die, they may die quickly from an arrhythmia, and they can die from other things. But the current belief is that asphyxia is the leading cause of death in dogs with who die from heart disease or lung disease. How would you minimize asphyxia? Okay, one is diuretics to get rid of the fluid. What about bronchodilators to open up the airways? There are virtually no studies to support its efficacy. And what about, do you look at pulmonary retractions? The apical regions of the lungs expand well, but the basal regions, you see retractions in which the wall is actually sucked in because the radius of curvature is greatest, and therefore, according to Laplace's law, the tension required is greatest. So the respiratory muscles fatigue there. So could we do something to strengthen the muscles of respiration? Could you name me 2 drugs proven efficacious and safe to strengthen the muscles of respiration?
We always talk about theophylline as
there's no argument about it. Now, people say, well, not very good studies have done, but the studies that have been done to watch it say theophylline, methylxanthines, definitely strengthen the muscles of respiration. Okay, name me another drug.
Can I pretend to have internet connection issues right now?
The drug is digitalis. Digitalis strengthens the diaphragm more than it strengthens the heart. And therefore, with no embarrassment do I say, I have many of my dogs on digitalis, because digitalis is one of the factors which will strengthen the diaphragm. And that's why I believe that a dog that needs pimobendan for heart failure because it's got a wet lung also needs digitalis, because pimobendan decrease symptoms by improving cardiac output. And so don't give more pimobendan because you may get sick from it. So why don't you pick a drug that will increase force of breathing by a different mechanism, and that is digitalis. And we know why digitalis works. But why not give them a small dose of digitalis, which is so small that it will not produce toxicity, because it's less than half of what the textbooks say to give, but will strengthen the muscles of respiration, which are become fatigued because of loading of the high pressure baroreceptors with sodium potassium ATPase. And so you use digitalis not as a positive inotrope, but to reestablish baroreceptor function, and that makes the animals feel better.
You said about half the textbook dose there of digitalis. What is that dose that you'd reach for?
Well, so I use only digitoxin because the therapeutic dose of digitoxin is very, very high because it's 95% protein bound. So it takes more of it. Digitoxin and digoxin have absolute the same toxicity. It just takes more of the digitoxin to get it because it's so much of it is bound. The normal dose of digoxin and digoxin you can have a much smaller dose because it's only 40 to maybe 50 or 60% protein bound, which is another story about why so many animals get sick from digoxin than digitoxin because they just get too much of it. So if you say a dog is required, a little dog has 0.125 milligrams of digoxin, you would probably take 0.5 milligrams of digitoxin, and and you can get by with half the recommended dose of either digoxin or digitoxin because it works by a different mechanism. So when I make a dog sick with digitoxin, you hold off one dose because the half-life is only 8 hours. But when you make a dog sick with digoxin, the half-life in a dog that's got renal insufficiency, where the digoxin is cleared, they vomit for sometimes weeks.
Now, you mentioned a few moments ago to consider all patients with significant heart disease as having compromised the lungs as well, respiratory disease. They're all together.
Yes.
Do you feel the same way about the cardio-renal axis?
That is the most burning, erudite question you can ask, because we know the cardio-renal syndrome is a real thing. In human medicine, it's tremendous. In veterinary medicine, it's equally as tremendous, but you don't hear it discussed nearly so much. So if the animal is receiving digoxin and has renal insufficiency, digoxin is cleared by the kidneys. Digitoxin is cleared by the liver, and the liver rarely gets so sick that it prolongs the half-life of digitoxin. So you rarely see toxicity with digitoxin. As a matter of fact, we have to balance organs of excretion and basis.
Robert, can we just step back a bit and talk about how would you define heart failure? Because again, being you such a fantastic clinician, we discuss at times that we, of course, diagnose dogs in congestive heart failure. Do you think we miss early signs of heart failure, forward heart failure, very mild congestion before there is a clear increase in respiratory rate? What are your thoughts on that, and how would you assess patients with maybe very early heart failure?
Solid, specific definitions for 4 things. One is a failing heart. I know exactly what a failing heart is. Exactly. It is a heart in which the heavy myromycin cross bridges cycle at a reduced rate. Okay? That's a failing heart. And by far, most animals develop first failing hearts because they're not symptomatic. If a patient has a failing heart and is symptomatic, then they also have either heart failure or congestive heart failure, which are defined by the symptoms. Okay, a failing heart is diagnosed in a laboratory. Congestive heart failure are diagnosed at the clinic. A failing heart is defined by heavy myromycin cross-bridge function. A heart failure has a failing heart, but it also has signs and symptoms. It's simple. It doesn't pump enough blood out, but there need not be congestion. The symptoms are silliness because of bad cerebral function, weakness because of bad skeletal muscle function, and feel their ears. Cold ears mean that there's inadequate circulation. But congestive heart failure, which is entirely different, they have symptoms because of inadequate emptying of a venous circulation. And what are those? We get edema, pulmonary edema, or pitting edema, if it's right or left-sided. And so we select different drugs based upon whether they're congested or not congested. we select drugs to increase cardiac output, but then we also select drugs to decrease the fluid accumulation. And so it's very important to determine why the animal is symptomatic and to select drugs specific for what's making them symptomatic. Most of the cases probably have a combination of the two. And they're a diuretic and need a positive inotrope.
In listening to you speak about digitoxin, about inotropes, I'm mindful that people are very, very different to dogs.
Tremendously.
I think if you said to many human cardiologists, oh, this person has heart failure, they need a positive inotrope, and you talked about something like pimobendan, they would run a mile and they'd say, this is madness. That's not something we would do.
Any positive inotrope makes a human with heart failure feel better, and for a short time, because it kills them faster. And therefore the FDA, don't ever try to develop a drug and sell it as a positive inotrope. Because the FDA knows very well the drugs that make them feel better, dobutamine, okay, makes them feel much better, but it kills them sooner.
Milrinone,
same thing. And the worst thing I did in my life was Mark Kittleson showed the benefit of amrinone and milrinone. And because the FDA thought I knew what I was talking about, and I was absolutely wrong, I said that, milrinone and amrinone kills. Yeah, but it kills for an entirely different reason, because it produces arrhythmias. And it does not in dogs. And so, because of my being nasty about getting it approved, the FDA did not approve milrinone and amrinone. And I did that myself.
Hindsight's 2020, isn't it?
Yep. But in humans, milrinone and amrinone is wonderful given IV for a short time. But given for a long time, it shortens life.
It's that concept in human cardiology of using it as a bridge to get them to a more definitive option, surgery, transplant, whatever.
Yeah, and a bridge. What makes them feel better? Okay, but it kills them. What makes them live longer and therefore end up feeling better? Drugs that make them feel a little sick when you give it to them. ACE inhibitors, because ACE inhibitors screw up their appetite and they just don't feel as well, but they live longer. I went on rounds with human cardiologists, and we went into this couple's room. The man was dying of a bad heart failure, and Dr. Feldman was the human cardiologist. People were very bright, and they knew what was going on. He said, what can I do? He said, all he wants to do is play one round of golf. And so he went to his office, got a form to approve the use of levosimendan, which is exactly like pimobendan. The lady who signed the form, because her husband couldn't even sign the form, had tears in her eyes. And the guy played golf for another probably 3 months.
Wow. And
died on the golf course. And so Dr. Feldman and I went to his funeral because we knew the family quite well. Yeah. And the lady came up and thanked Dr. Feldman. Thanks for giving him those 3 months. And you see, pimobendan and levosimendan would do that, but they also kill you sooner.
So do you think quantity of life and quality of life is different in human and veterinary cardiology? Do you think the way we look at quantity versus quality of life when we decide treatments is very different between humans and vets?
Yeah, no question about it. The best way to assess quality of life unequivocally is exercise tolerance test. Very few people do it, we do it kind of by the seat of our pants. We say, well, he's not walking very well. But what we can do is actually walk them and see, and owners can do this, and we train owners to do this. We have them walk. See, the rule is, if the drug is going to work, they increase the duration they walk, the distance they walk by maybe 500 meters. That is a very reliable test for exercise tolerance. And but we don't do that. We depend upon the owner to make the observation. We don't formally do a test. We have in our clinic a circular path. We have a person walk the dog. We find that it definitely increases the distance they walk. Exercise tolerance is very valuable in humans, and they do the exercise tolerance test. They measure the distance they walk in meters in 5 minutes.
I think in dogs, it's so difficult to get a feel for that without trying to standardize it. I know that Luca Ferricin has done some great work on standardizing, the exercise test in a group of Labrador retrievers when he was working with a team at Minnesota. And that was super interesting to read the papers that came out of that work. It proved you can standardize it and you can use it in dogs, but there was a training period to get the dogs on the treadmill. It's labor intensive. But then if you flip that around and you ask the owner, how's his exercise? Oh yeah, great. He can exercise perfectly. What's his exercise? We don't really take him for walks.
Yeah. It's very, very, very interesting. I mean, the FDA cares almost nothing about whether or not the cardiac output goes up. They care about how far they walk for 6 minutes. And it's very hard to know how to do an exercise test on a dog. I have only 2 people who exercise my dogs. They do not pull them. They coach them. And you have to do it at night when it's quiet, because there's a lot of barking. It bothers the dogs. And we were the people who first standardized the test, but it was very hard to know the difference between pulling and just gentle nudging.
The main thing that would inhibit my dog from exercising is if there was rainfall at the time.
Yeah,
there's a lot of things to consider.
Robert, when we think about your work, we think about cardiac physiology. And it would be really interesting if you could share with us some differences between the cardiovascular system in different species.
I hear that you two are very skillful echocardiographers, but I've seen what you do. You lay the animal down and you wheel this $100,000 instrument around, and you've got a bunch of transducers, and you use one that's a high frequency, which gives you good resolution, but won't penetrate well. And then for horses, you use low frequency because it penetrates well, but doesn't give you good resolution. And you switch around machines and transducers, and this big expensive thing. But let me tell you what a bat would do. Take a bat. Bats love, insectivorous bats, love to eat bugs, mosquitoes. They don't like the entire mosquito. They like the nose, because the mosquito sucks blood, and the bat likes to kill the mosquito that has nose full of blood. So how in the world does he know that? Well, a bat has a scream, eek, eek, like that, and a real low-pitched scream with low frequency and a high string. And he does a noisy scream, which has both high and low frequency. He finds where the mosquito is by the low frequency scream, because that gives you good distance. And then he uses the high pitched scream to find out if the nose is full of blood, and that's what he's after. So he has in his scream is both high and low frequency. On the other hand, you, unfortunately, have to switch heads. Okay. So you're not. You're not limited. Yeah, you are limited.
As someone with a zoology degree, I'm always going to say, evolution is as close to perfection as you can get.
Yeah. But you see, a bat can do it. But you know why a bat would not be a good cardiologist? A bat would get on a person's chest and scare the daylights out of them because they're bats.
Not an option then.
Yeah. A giraffe. Okay, a giraffe. Have you ever? Of course, you're young. When you jump out of bed, I don't think you get lightheaded. Maybe you do a little bit, particularly if you're.
We're getting to that point now, I think.
Yeah, because when you jump out of bed, your heart goes above the level of your buttocks and legs, so the blood pools in your legs. Less blood gets back to the heart. According to the sign of Frank Starling law, the heart contracts more weakly, and your brain goes above the level of your heart, and blood flow to the brain falls. So you get postural hypotension. A giraffe drinks water from a brook 10 feet below the level of his heart, head down there, and then jumps up when he hears something in the distance, and the head goes way up above the level of the heart, meaning the heart has to pump blood 15 feet higher than normally. And he would think he'd get pooling of blood in his legs. And it would make him get terrible postural hypertension, which he doesn't get. Why? Because he's got what's known as a giraffe suit on him. A giraffe suit. Have you ever gone to the zoo and touched a giraffe's neck and pulled out on its skin? The giraffe's neck is thick, tough skin. His legs are thick, tough skin, so he can't pool blood, and he can siphon blood up to his brain because it's like siphoning blood out of a gas tank. Okay, and so the giraffe doesn't get lightheaded and can run away from somebody that's going to do him harm. So giraffes would be wonderful fighter pilots because the giraffe would never get acceleration problems because he can't pool blood. When a fighter pilot flies and does aerial combat maneuvers, they grunt, like that, because they raise the pressure in their chest and blood will not pool. And that keeps them from passing out. So they'd be good fighter pilots, but they wouldn't do well in an airplane because they couldn't. So be glad that you're not a giraffe. Now, why would you want to be a spider?
Why would you want to be a spider?
A spider has a heart. It has a one ventricle heart, and it pumps blood into an aorta. Okay, he will not die of diastolic heart failure. But don't you know that 50% of your symptoms in heart failure are caused by diastolic malfunction, correct?
Yep.
A spider does not get diastolic malfunction because he doesn't fill like you do. You fill when the amount of blood in your lungs is enough to push blood into the ventricle. A spider fills because there are skeletal muscles going from the epicardium, from the pericardium and epicardium to this exoskeleton. So the spider actually pulls his heart open, so he cannot get diastolic dysfunction. So that's why you should like to have a spider heart. Now, the downside of that is that the spider heart's SA node is in the elbows.
Wow.
When the heart beats, he pumps fluid into a tube that goes around the blood vessels, and it fills those blood vessels well. So the spider has wonderful diastolic function, but its systolic function depends upon its legs moving.
Wow.
Very ingenious.
It's amazing, isn't it? What's out there across the different species.
Less about this. Why would you want to be a guinea pig? A guinea pig you can ligate one coronary artery, you can ligate both coronary arteries, and nothing happens. Why? Because they've got spectacular collateral circulation.
Wow.
That's collateral circulation, so you never get coronary artery disease. Very, very nice.
Thank you so much. That's brilliant. Brilliant.
It's wonderful. I have maybe a final question. I remember about manatees and dugongs having the double apexed heart.
Beautiful, beautiful. Why?
Tell us about that. What are your thoughts on that?
I ask everybody this question. What about a structure? What about a function suits you to reproduce? Because that determines how long you live on this earth.
So it's survival to breeding age, isn't it? All our genes want is to get passed on.
Yeah. And so what is it about a manatee that has no ventricular septum, a right ventricle hanging from the right atrium and a left ventricle hanging from the left atrium? What about that suits them to survive? And their answer is nobody knows. So I can't tell you why, but nor could I tell you how a bird can fly from a branch in your tree down the Yucatan Peninsula and fly back and land on the same branch. They have ability to migrate by actually seeing the magnetic lines of force around the Earth, because they have an eye that allows them to see in 4 dimensions. They can actually see in their brain the lines of force, and they know to fly to those lines of force.
Unbelievable. A couple of years back, I was lecturing in Orlando, and I was privileged enough the day before my talks to go and see some manatees out in Crystal Springs. It was unbelievable. And I mentioned this in my talks. And I said, interesting fact about the manatee, double apex, no ventricular septum. And somebody said, why? I couldn't answer them, but I'm glad that nobody can answer them.
Nobody. Very interesting. Very interesting.
Wow.
Fantastic.
Unfortunately, they don't live very long because they're so slow moving. They get hit by boats. And there's so many interesting things. But what I would like, though, is to have you stop talking about the Frank Starling mechanism, because neither Frank nor Starling invented it. A guy named Elias Sayan, a physiologist from Russia, who came to the lab and showed that the frog heart pumped out more vigorously the more blood in it. And then Frank and Starling came to that lab and saw that and published it as the Frank Starling mechanism. But it was really the Sayan mechanism. So I call it the Sayan Frank Starling mechanism.
It's right. Because I always heard that there was also an Italian physiologist, Mastrioni, I think, that also published before Frank and Starling. He published a lot, but he published in a smaller journal in Italy. And of course, Frank and Starling were the big guys from the UK and so on. And their paper was more read and seen than the Italian paper. So I didn't know that it came even before. So in fact, came from that Russian physician. It's very interesting.
Yeah.
Very interesting. Yeah.
How unlike the Germans and the British to take credit for somebody else's work.
You have to give them credit because they made the observation in mammals.
Yeah.
Can I just ask you one last question? I had the pleasure to listen to a lecture that you gave in Ohio to your undergrad students when I was there for a board review. And you were talking about the first and the second heart sound. And you're saying that people generally say that the sound is caused by the valve's closure. The sound is due to the valves closing, and that's wrong. Can you explain as that?
Sure. If you take a look at a mitral aortic valve and out of the heart, and you slap two of them together, do you think you'll hear any noise? No. In particular, if you slap them together inside your chest, you'd hear nothing. But what happens is they close, suddenly decelerate the blood. See, when the left ventricle contracts, it slams closed the mitral valve so blood doesn't leak back into the lungs. Okay? And slamming closed the valve doesn't produce the noise, but the mass of the blood in the ventricle suddenly decelerating throws all the cardiohemic structures into oscillations, and that's what produces the sound. And so if you look at the way the heart beats, the sound is produced not by the valves closing, but the valves closing suddenly stop the blood from moving, and that's what causes the first heart sound. And if you listen to the first heart sound, in most dogs, you hear a lub-dup, lub-dup, lub first, dup second. But if you listen carefully or record it, it's not a lub-dup, it's a blub-dup, blub-dup. And you hear blub, but you don't hear it as two sounds. So if you say blub, it sounds like one sound, but it's really a lub-dup. And in big dogs in particular, you hear never a lub-dup, it's a blub-dup. Little dogs, lub-dup, lub-dup. Big dogs, blub-dup, blub-dup. So there's three sounds. Second heart sound is also very interesting. That dogs split the second heart sound in inspiration for a different reason than humans do. Fascinating differences that suit us to survive. How it does it, I'm not sure.
Fantastic.
Amazing.
Fantastic. Stuff. Thank you so much for sharing all of this with us. Really, it has been a huge pleasure. Thank you very much for your time and knowledge. Thank you.
Yeah, Professor Hamlin, we've been honoured to have you with us today. Honestly, thank you so much, and I'm sure all of our listeners will feel the same way.
Good.
Absolutely.
Thanks.
We wish you all the very best. Thank you so much.
You also. Stay well.
Thank you.
Bye now.
You have been listening to the Animal Heartbeat. Thanks very much for our listeners.
Keep in touch by finding us on social media or sending us an email on animalheartbeat@gmail.com. Please remember to like, follow, and share to help us find new listeners. And make sure to check out our previous episodes wherever you get your podcasts from or on our YouTube channel.